There are 1,000,000 ways to die. We just wanna talk about it. Codeheads.
Welcome back to 2026 Codeheads.
Welcome.
New year, new us.
Well, same us, but new year. For better or for worse.
Yeah. But it's, 2025, we decided to kick this off, do it, which, I'm proud of us because sometimes we talk about things and we don't do it. So we did it. So check. And we've gotten, following. So yay. Thank you to everyone who listens to us and checks in and, engages with us. We love it. And we've got some exciting stuff planned for 2026.
We have guests coming aboard.
Mm-hmm. We do.
We have other people to pontificate on these topics which we present, which will offer a little bit of diversity. But truly, no, it will be, exciting. We have some great people in mind, some brilliant people that can join us. And I think the community will appreciate what we'll bring to the table going forward.
And we may be calling it guesty besties, but
we may not, but we'll see how it goes. I'm coming around.
Guesty besties.
Try.
It's because we're besties, so it's tough. We have to give a separate name. But yeah, so that is us in a nutshell and our 2026 jump off. And we wanted to start the year by talking about something so exciting. You might see it on my shirt, but we want to talk about ROSC.
ROSC.
Yeah, ROSC. That's what we love, right? We love getting that win. We love getting that pulse back and giving a high five and taking care of our patients. And, that's the whole end goal. The whole time that we're resuscitating a patient is to get that return of spontaneous circulation. And there were a couple changes with the AHA guidelines and, with ERC, ILCOR, all those good folks that do a lot of work. But one of the big things I wanted to point out specifically from the AHA is just that there's a little bit of a change in verbiage because we always talk about ROSC, and I'm going to refer to ROSC this entire pod. But ROSC is really defined as the recovery of cardiac function that results in the return of circulation without the need for any sort of mechanical intervention. And so that's when a patient just regains their pulse. However, there is also ROC, so return of circulation, and that is the term used when circulation's achieved through mechanical means, such as a patient on ECMO. They will have circulation, but a little extra help on that end. So that's the big exciting news with verbiage changes. But then there's been a lot of really significant updates aimed at optimizing recovery for our patients. And I think one of the big things is moving from the verbiage of TTM, so targeted temperature management, to more temperature control. So I think that was a big thing. And they give a wide range, and we'll kind of dig into it deeper, but there's they want to maintain from 32 to 37.5 Celsius for unresponsive patients. And that has now been recommended as a minimum duration of 36 hours. And I think we all know previously it was 24 hours. But they really want to focus on getting patients, honestly, normothermic and prevent hyperthermia. They want to prevent fevers in these patients, which I think is important.
And to just break that down a little further, so fever is a common occurrence following ROSC, 20 to 30% perhaps of that patient population. And that 32 to 37.5 range, to break it down further, 32 to 34 would be the hypothermic temperature control, and then 36 to 37.5 would be the normothermic temperature control. And this is coming from the AHA. This is not coming from me. And then the ERC, the European Resuscitation Council, recommends just less than 37.5. That's the way they define it. So whatever you want below 37.5.
Yeah, let's not let these people have a fever. That's the bottom line.
Avoidance of that hyperthermic state.
Yeah, let's keep it real.
Yeah.
And talking about keep it real, there were some changes also for the post arrest period. So once we obtain ROSC for vital signs and hemodynamic monitoring, which I think were semi exciting.
Some minor changes. Yeah, so let's go to SPO2 first, which I understand you're not a big fan of.
I hate SPO2
Do
for
you
various reasons, but it's highly inaccurate. People don't look for a waveform, and if it doesn't have a really crisp waveform, it's not going to be giving you an accurate number. It is shown time and time again in research not to be accurate on people of color or anyone with deeper skin pigmentation. And we also know that ladies love getting their nails done. Not me, but other ladies, and which are beautiful, but it's not going to be able to read and give you an accurate reading through those lovely nails, which we can't just whip off in the middle of a resuscitation event.
And there is a risk with that inaccuracy. So if you're going to depend on that number, and let me just give you the numbers. So prior to the 2025 updates, it was 92 to 98% SPO2. Now they've just widened it a bit. It's 90 to 98%.
Yep.
Now, what we want to avoid is hyperoxemia for sure, because if I have 100% SPO2, which makes me feel good, it's like, oh, look at my number. I'm just 100%, but that's not good at all, because this number, this SPO2, does not indicate to us, it does not inform us of the true arterial oxygenation level, which we want to have between 60 to 105 per the AHA.
Correct.
Hyperoxemia, why is that bad? Well, oxygen is a free radical. So if we blast these patients with oxygen, we're going to upset the balance between free radicals and antioxidants. What does that mean? That will cause oxidative stress. What are we dealing with? Vulnerable tissue. So we don't want to make any more problems by loading these people up with O2. So 90 to 98% is our new range per the AHA. Moving down the algorithm, so we have airway breathing. Let's go to circulation. Circulation is referring, in essence, to their blood pressure, their hemodynamic stability. Following ROSC, the AHA now recommends, or they do still continue to recommend, a minimum of 65 for the mean arterial pressure. What there's no mention of any longer, none that I could find at least, it's certainly not on the algorithm, is achieving a minimum of 90 systolic. That number, cannot locate it, so simply achieve a minimum of a 65 for your mean arterial pressure.
Which makes sense, right? Because a mean arterial pressure is gonna, you're able to guide to a map easier when there's two different parameters. Then people are like, oh well, the map's 65, but the systolic
Yeah.
88 or 89. We should sort of I think some people get really kind of tripped up with the algorithms, as I am with my own words right now. So I think I think it's important to guide it, use that one thing. And the map is something that we should be using to guide our blood pressure parameters and if we're going to use pressors or not. And I do think that's also important, is that, the guidelines don't really give us a directive on which pressor to use. In the past, they had been very specific about, which, and I'm talking a long past ago, but it used to be like, oh, if you think it's cardiogenic shock, use this. If, they used to give us very specific kind of parameters of what pressors to use. And they've given up that leeway, really. The only things that the guidelines really note are that epi and dopamine have been less favorable in cardiogenic shock, and that have led to an SCA. So, something to consider, but also, it's nice that we kind of have the leeway to use what we need to use. However, Mike and I've talked ad nauseum about this. Norepinephrine seems to be the drip du jour that people are using for arrest events.
And obviously, when we're dealing with the blood pressure following ROSC, it is not going to be stagnant. It won't remain the same. There's going to be a lot of volatility.
Right.
What we see right away is not going to be there maybe in 20, 30 minutes. If we're filling them up with epi, push dose epi during the arrest, every 4 minutes, they got 8 milligrams, maybe more, depending on how long the code lasts. That's going to give us sort of an artificial reading on our blood pressure. So let's see how they are after all that epi sort of, drains out of their system.
Right, and I've absolutely seen that where a patient is, like, epi dependent almost, like, we
Right,
push
right.
the epi and we're like, "Oh, great, phew," and then, you know, although as soon as it starts wearing off, we're like, "Oh, dear," and sometimes they even lose their pulse again, and you're like, "Psh," you know,
Right.
and those are the patients that are very responsive to an epi drip, but yeah, it's something to think about that we don't often think about. And also still, filling that tank and ensuring that they have enough fluid on board. Because sometimes during the event, we don't give as much fluid as we think.
And for pre-hospital with, a short duration or short transport times, at least where I worked, we would be able to get those numbers. So vitals are great when we showed up, when we delivered to the hospital. But then from there, I don't know what happened. Not my problem. Just so, but now that I work in hospital, it is my problem. And it's fascinating to see and such a challenge to treat that volatility.
Yeah.
Figuring why, why is this occurring?
And also, this is just pointing out why it's still so important to have that pre hospital to hospital relationship so that we can kind of information share and understand, kind of both sides. Because I feel like sometimes in the past, EMS will drop off a patient and we're like, oh my God, ugh. Look at them dropping off this patient with no pressure.
That face.
But then, but that's not actually the case. You guys had, so now that we can information share and see the vitals and, we do have better relationships and communication and sharing of information. I feel like we both learn a lot from both sides.
Absolutely. That input I find, so valuable, and when I first started, I wouldn't get it because I wouldn't be proactive to ask for it. And then eventually I wanted to know everything because it's only going to serve me when I transport them to bring you perfect patient on a silver platter.
Correct. Yeah. And then we can understand too your side of what you
Mhm.
saw. Um, and I think one of the other things with ROSC, so we have these vital signs, and that's really important, and how we're treating them and how we're managing them, and looking at maybe what caused, positive causation for what caused the arrest. So just because we have our, ROSC and the patient is circulating, now we got to try and figure out what caused that event. So we're still kind of looking at our H's and T's to figure out if we didn't figure it out during arrest, let's figure it out post arrest. That's when we can draw and send off some labs and, get an EKG, get an EEG, like start looking at what perhaps has led to this event and what we can do to prevent the patient from rearresting, and furthermore, start looking at, that neuroprognostication for our patients, which I think is crucially important, not just for us. I mean, obviously, as healthcare providers, we want to know, like, did we really save them in an
Right.
awesome way? But also for family members that might be coming in to see their loved one that are really stressed out that want to know, because when we say, oh yep, we saved them, and we're all high-fiving as the patient as Ross, we want to make sure that we can also share with the family, like, if the patient is unresponsive or sluggish to wake up, we need to be able to tell them, hey, what's the long term.
Right. We're going to definitely dedicate at some point an episode to the H's and T's, to the reversible causes. For lack of a better description, I really consider that the fun part is trying to figure out what made them go down. It could be multiple, it could be two H's and a T all working together, or just one, or maybe we don't know. Maybe it's going to take some time to ascertain, if ever. So that is also a fluid concept, is figuring out what went wrong. So we're trying to find those reversible causes as, like you said, we're dealing with this neuroprognostication for those that, lack a meaningful response or are comatose. So we have to obtain a 12 lead. We're going to do that right after we get ROSC. So we didn't talk about that because are they going to go right to the cath lab? That
Yep.
that 12 lead will tell us that. We're going to get CAT scans, MRI, point of care ultrasound. We want to know the brain activity. Is there any gray white differentiation with the imaging? I mean, labs, everything, electrolytes. So this is really us doing some really quickly, a lot of research into the causation, and then we could target our treatment plan. And if they code again, we could target the resuscitation attempt.
So it is important to think about all those reversible causes so that we can really target our interventions with patients and make sure that we're specific as possible. Um, and that is actually brings me to one of the next changes with the neuroprognostication of patients, because I feel like, sometimes when we're giving family members feedback and, sharing with them what we think is going to be the outcome when we're giving them that neuroprognostication, it's almost like figuring out the weather. You know what I mean? Like we have a lot of
Oh,
data
yeah.
points and, but it's kind of like it might snow tomorrow or be really sunny. And that is kind of what we're doing with family members, which kind of stinks because it's like, bring a raincoat and bathing suit and we'll see
Yeah.
how it works out. Um, but one of the big things with the guideline changes that came out in 2025 is that they want us to avoid using just one single data element, and looking at them as a whole, which I think will help us to better, you know, to better predict the outcome for our patients. So they want to use those clinical exam findings, like looking at their awake state, if they can follow commands, their glaucoma scale, and how that's changing. There's some biomarkers that we
Yep.
can draw and send off, the EEG findings, so that neurophysiology, the neuro imaging. So, as Mike mentioned, the MRI and the CT scan, really to kind of look at those all together to
Yep.
give either a favorable outcome or not. And I do know this is not part of the guidelines, but looking forward, there is some research and growing interest in also looking at invasive neuromonitoring, like intracranial pressures and cerebral blood flows and brain tissue oxygenation. Also, it's being looked at, but that neuroprognostication bundle was really a big change, I think.
Bundle is a key word because verbiage wise, the HA I read calls it a bundle of care sort of approach. And they definitely utilize the term multimodal approach, which is basically what you were just stating, not relying on one or two metrics, but a real thoughtful, broad, approach to that sensitive state, that neuroprognostication. Yes, there was an additional serum biomarker added. I will nerd out on that on another, episode, but we
Part two.
definitely need to break that down because I really appreciate that they've added more time to neuroprognostication in these guidelines so that it makes us appreciate that moment after, as we said, the high fives with
Right.
Ross.
And we're going to talk later too about, not only the ROSCs and the high fives and all this good stuff, but adding in the debriefing too, which is because as you brought up, it's a sensitive time, not only for family members,
Yeah.
but it's also a sensitive time for us, as providers and the responders.
We want to give a direct answer. We want to tell you this is going to happen, but we don't know.
Right.
At that moment, we certainly don't want to make any promises. It's impossible to predict until it plays out.
Right. And I think it's confusing for family members when we're like, well, we got them back. And they're like, oh,
Yeah.
great. And they think,
Yeah.
you know, their loved one is going to be dancing a jig, shortly.
Right.
And
Right.
that's not always the case. So
Sad.
not to end on a Debbie Downer note, but we will next pod we're going to get into a little bit more about this neuroprognostication bundle and the biomarkers, and as Mike said, he's really going to nerd out and dig in on that.
Hey,
And we'll talk more about it, but we do want to hear from you guys if there's been any changes in what you are doing clinically, pre-hospital, in hospital, based upon these guideline changes. And if you guys have any feedback, insight, you want to be a guesty bestie, feel free to reach out to us on Instagram, LinkedIn, wherever you can find us, our website. And then we also have an email,
you.
codeheads411@gmail.com. So
Yeah, reach out, please.
yeah, reach out and touch someone. Touch us. All right. Bye.
Well,
There are 1 million ways to die. We just wanna